I'm Kathy DiGregorio. This is a huge topic, and you know from just the press and your own practices how difficult this topic can be. So as I go through, I'm going to just give you things to think about. Of course, none of this is going to be perfectly adaptable to your own practice. I'm a pain doctor. I've been doing this for 18 years. Our pain center is a multidisciplinary center, so I'm bringing this to you from that perspective. So we're going to focus on what the standard is, what the expectations are now, and what you should, hopefully you'll go away with a little bit of a different understanding of how we think as pain doctors, when it's appropriate to tap into your pain doctors, and what you need to think about if you don't have pain doctors local to you. So here's the, I just like this slide, the pill head slide. I think it's more and more relevant, so stuck that in there. Every day, 115 people die of opioid overdose. It's a lot of people. The CDC has determined that the economic burden to our country is $78 billion a year. About 29% of people on opiates abuse them, 10% have an opiate use disorder, and about 80% of the patients currently using heroin abused prescription opiates first. So it's important for us to think about this because we have an opportunity to impact people who are using opiates, people who may go on to using more dangerous things like heroin, and to try to help improve their lives. These are the objectives. Try to understand the complexity of managing patients with chronic pain, to conduct a comprehensive evaluation and assessment of the chronic pain patient, to determine suitable non-pharmacologic therapies for managing chronic pain patients, to select appropriate tapering processes for opiates, to interpret urine drug screens correctly, to establish accurate documentation and methodologies for people receiving prescriptions for opiates, and to identify signs of addiction along with referral strategies and treatment for people who you feel are addicted or may be at risk. In 2011, there was a report that came out that outlined that effective pain management is a moral imperative, and that pain should be considered a disease with distinct pathology. There's a need for interdisciplinary treatment, and this serious problem of diversion and abuse comes along with opiate medications. This is different from what we learned in the late 90s when it was the era of give them whatever they need, and you can't feel their pain, so it's the fifth vital sign. Just treat them, and when physicians honestly were being sued for undertreatment of pain. So now we've come full circle, and we're on the hot seat for creating addicts out of the people from the So it's kind of this odd balance that we have to work and hopefully help get people better. We're going to talk about the long-term efficacy and the risk of abuse in non-cancer patients. So you're going to see CNCP, which is chronic non-cancer pain. Going forward. The Cochrane review looked at a large group of patients receiving opiates. 20% stopped taking the medications because of adverse events. 10% stopped because of poor relief. And what they also found in this long-term review was that there was poor evidence that long-term use of opiates was really giving patients significant relief. And they define long-term as greater than 6 months. So now think into your practice about how many people you've either inherited or you know that have been on medications for 40 years or 10 years or anything greater than 6 months. It gives us a point of reference. Before we get too far along, I want to talk about 3 big pain complaints that we see, and I know you all see, that we don't think really need to be treated with opiates, and that will help just give you, I just want to get these 3 things out of the way so that you can think about these patients a little differently. Fibromyalgia is the first one. This is the person over here with all the red dots on them, all the points of tenderness. Fibromyalgia is not supposed to be treated with opiates. The treatment for fibromyalgia should be tricyclic antidepressants, SNRIs, therapy, cognitive behavioral therapy, physical therapy, aqua therapy. Sometimes we can do trigger point injections, which isn't actually on this slide. But anything other than treating them with opiates, because this is a very long-term condition. These people suffer for most of their life, and what you're just trying to do is help them cope and teach them how to impact the times when the fibromyalgia increases, which are always in times of stress, which is true for anybody's pain condition, and try to help them from a multimodal approach so that when they get into trouble, they can go to an armament, a toolbox of their own and help themselves with your assistance. But opiates are not the way to go for fibromyalgia, and I've been spending about maybe the last 2 years getting people who come with fibromyalgia to understand that this is not the treatment. Low back pain, which is kind of a loaded diagnosis. You would argue if any of you have herniated a disc or had radicular pain that you may not have made it through the first week without some opiates, and I would agree with that. But for the people with that chronic aching low back pain, you have to really think about whether opiates in the long run, beyond a couple weeks, is appropriate. And things, I don't know, extra strength Tylenol seems to work in older people. Some patients, they're either fans or they're not fans. But the reality is NSAIDs can help these people if they can take them, but also your tricyclics, gabapentin can help you. On the fibromyalgia slide, I think SNRIs were on this, Cymbalta. On this one, we have, gabapentin, amitriptyline, naproxen. These medications are good alternatives for patients to kind of try them, remembering that when you start gabapentin or things like Elavil, Pamelor, it takes time, and you have to set them up correctly. You have to say to them, we're going to start this, and you're not going to feel immediate pain relief, but you'll get pain. The pain relief should come over days. And so what we'll do is recognize the patients who can't sleep because they're in terrible pain and give them something sedating like a gabapentin type medication, Lyrica, or tricyclics, because it makes them tired. And we give it to them at the end of the day, and we load the doses always late in the day so that hopefully they can feel better during the day. They can be clear and build their level to a reasonable amount. I can certainly get into that more, and these are, of course, very brief ways. Your local interventional pain doctor, plug for myself, can do injections of all different types if they're appropriate, to help some of the low back pain patients. At the end, we'll certainly be able to take some questions and we can get into some of this more. The lecture's really on opiates. And the other group of people that suffer something fierce are the neuropathic pain patients. These people are the people that feel like they have a blowtorch on the limb. Our diabetics suffer terribly from this. And we're back again. See the theme? Gabapentin, SNRIs, tricyclic antidepressants. It really works for this nerve-type pain and can make a big difference for these patients. Other things like spinal cord stimulators and more advanced things are also possibilities if their sugars are in good control. So there's lots of ways to treat these very common things, and don't just jump immediately to opiates. So treating the pain patient requires a biopsychosocial approach, which is the same thing as saying a multimodal approach. So medications, therapy, physical therapy, knowing what their family connections are, all of these things are important for the chronic pain patient. So cognitive behavioral therapy, acceptance, commitment therapy, rational pharmacotherapy regimen, exercise program, counseling and weight loss, and social support. When a patient comes to you in pain, they do not want to hear about all of these things on that first day, right? And that's okay. It's just, you're going to start here because we're Americans, right? And we're entitled, and we have to get better yesterday, and that's the way it is. But you're going to need to think about these other things and even bring them up, and especially in patients who you think will be a little refractory or difficult. You have to bide your time and give them these different options at different times. I used to work with a guy when I was at Jefferson, and he had severe ADD, I think, and he'd say, I was a fellow, he'd say, we got to get them aquatherapy. I'm like, they're 92. The woman's like, I haven't had a bathing suit since I was 70. I'm like, let's not put her in a pool. Let's just because then when you do something ridiculous, tell the 92-year-old person, by the way, in the late 90s, to see a 92-year-old person, they were like you protected them. They were like a fossil. Now, people are living well into their 90s, and they're active. So it's not the 90s of today; it's the 90s of then. And to put them in a pool would have, been the end of the poor person. So you have to meet people where they are. But coming up with a program, and we're lucky now because all of these assisted livings and all the 50 and over communities, they're really focused on health and well-being. So we're at a time when these are a little more accepted, especially in our older generation. here are the risk factors for opioid. This is probably one of the most important slides that we have. A personal history of substance abuse, family history of substance abuse, age meaning a young age, history of pre-adolescent sexual abuse, mental disease, polysubstance abuse, poor social support, cigarette dependency, and repeated history of drug and alcohol rehab, and that also includes DUIs. These factors can tell you a lot about whether you're going to set somebody up at risk when you're seeing a patient. So we realize that there's a serious health crisis. We realize that there's a fair number of pain complaints that we should not treat with opiates. There are people who, this is not a lecture about not giving out opiates. Don't misunderstand me. This lecture is about how to give opiates the right way to people, but pick the right diagnosis. Always make sure you understand why you're treating and what you're treating, and how long you're going to treat them. So, we'll get into all of these strategies as we go on. Assess and manage the comorbid conditions that will help you get these patients off of the opiates. So there's other conditions that happen to these people simultaneously that you have to be aware of. And a multimodal approach, if you can do it, is helpful. And if you don't have, I'm fortunate, I have a psychologist, by design, we have a psychologist in our office. Now, I recognize that that's not what most people have or will have, but connect to your community and connect out to figure out who's around you that can help you, because the opiate patients will consume you, as you know, and you will need other people to help you out and to actually help the patient. These are the comorbid problems that we're the most concerned about. Sleep disorders, mood disorders, and anxiety. There are a number of patients who use opiates to treat these problems for their pain condition also, but they're actually less treating them for their pain, but they're really treating their mood, their anxiety, and their sleep disorder. And if we can impact those other things, we can be more specific about our use of opiates, more judicious. When you have a patient that you just cannot, boy, I thought, 5 or 10 milligrams of Percocet or OxyContin, I thought that this should really have worked. I can't understand why they're just not getting better. And over time, think about this. Persistent pain comes from sleep disturbances, untreated depression, untreated anxiety, substance abuse issues, other medical problems, functional disabilities, and cognitive disorder. And as our population ages, and like I've said, I'm so thrilled to see so many. My oldest patient's 102. Isn't that sweet? For a 102-year-old person to come to a pain doctor, and she says to her daughter, who is 80, by the way, next time I'm not going to wait 2 years to come in here because I can get better. And I'm thinking, you're playing with house money. Like 2 years from 102 is like, But you know what? For her, she was very cognitively aware, and so she's a terrific, example of aging well. And I was so happy because there's these 95 to 100-year-old people who are only taking a vitamin, and they have great genes, right? But she had every problem in the book. She survived cancer. She survived aneurysm. So she was really a testament to the medical care that you all fight for every day. And, here she was, 102 years old, thinking in 2 years she's not going to wait. But some of our older people, and you have to be so aware of this, I'm sure you think of this all the time, there's a change sometimes, and all of a sudden you notice, this person's not getting better. They may not be taking their medicine. Just because you give it to them doesn't mean they're taking it. Just because they tell you they're taking it, they may not be taking it. And it may not be that they're trying to lie to you. It just may be that they are not aware of the fact that they forget it. So if they have a family member come in with them, sometimes that's helpful, sometimes it's not. I happen to like the family member thing unless it gets fractious. However, I actually ask patients that I suspect with cognitive disorder to take me through their day. I don't get up, and they get a little embarrassed because they don't know when the right time to get up is. I'm like, it doesn't matter if you sleep till 10. When do you start your day? And I ask them, now how many pills do you take, 1 or 2? It's that granular, because you'll be able to tell whether these cognitive disordered patients are actually taking the medicine, and a lot of times you find that they're not, or they don't want to get hooked on it, but they don't want to disappoint you. So, this is where we have to be very specific. There's a national comorbidity survey that looked at 6,000 people, and this is what stands out. The next slide is horrible, so I apologize, but all you have to know, look at this slide, crazy, right, is that they looked at, out of the 6,000, there were 382 chronic pain patients, And they found that 22% of the chronic pain patients had a mood disorder, as opposed to 10% in the general population. The chronic pain group had a 20% rate of depression and a 35% rate of anxiety. In the general population, it was 10% and 18%. So what you actually see is that with chronic pain, anxiety, depression, and mood disorders are increased by twice. So I think that's just some excellent food for thought as we talk about treating some of the problems that we are worried about. So if you're an internal medicine doctor or you're a PM, if you're a non-psychiatrist, right? So my hat's off to all of my psychiatrists in the room. But if you're a non-psychiatrist, we need something fast to be able to figure out, is this person in danger? Are they not? And so these are a million, right? Too many mental health screening tools. I like the PHQ-9. You can pick what works for you. These are simple tests that patients can take as long as they can read. And they're asking questions, and it helps you. You score it, and it gives you a sense of, mild, moderate, severe. Now, I'm sure that our psychiatry friends would feel like, that's far more complicated than that, and it is. A screening tool is exactly that. You screen them. If somebody is a real outlier and you're struggling with them, then maybe you need a psychiatrist to take a look at them and say, yeah, the tool doesn't mean anything, or you're missing this piece. Some people have never been treated for illnesses and psychiatric issues ever, because no one ever looked at them. So these screening tools are really important when you assess chronic pain, because like I told you, your patients that are the most difficult and that are the most refractory often have other things going on, and mental illness is one of them. Sleep disorders are the other, and I'm grateful for the tricyclic antidepressants in the right patient, because they help a lot. They get patients that can't sleep, can't function. Chronic pain causes emotional distress, fatigue, and like I said, these sleep disorders, they are unable to cope if they can't sleep for a number of days. And so 50% of the patients with pain have a sleep issue, and this is where your neuropathic pain medications come in if you have the correct problem. OUD is opiate use disorder. CNCP, remember, is chronic non-cancer pain. So I want to bring this up now because this is what we're the most worried about, right? An opiate use disorder. We have these patients come in, you're in a hurry, you've got to figure out quickly, is the patient taking the medicine right or not? So they looked at chronic pain patients, and the lifetime prevalence of a chronic pain patient for an opiate use disorder is 35%. The more recent studies have actually shown that it's actually higher, and that it's actually 41%. So the people that are on opiates for a length of time have a 41% chance of developing an opiate use disorder, and that's a worrisome problem. And so we need to establish some tools that we can take to your practices to help you discuss things with patient, have a plan to treat patients that are difficult. The easy patients are easy, right? The people that come in and they sprained their ankle and they need a few days of something, or they herniate a disc and they're in agony, and you know that in like 6 weeks they get some steroid by mouth maybe, or physical therapy, and maybe Percocet here and there. They're easy. It's the people that you can't get better, that are banging your door down or calling incessantly. These are the people that we really have to impact, and they're the ones that are really causing the opiate problems that we're most concerned with. And the thing that's happened is that it's a lot easier just to give the patient the prescription, right, than to figure it all out. And of course, your billable hours are, it is what it is. So communication, I think, when you do pain management in your practice, in my practice, communication is the single biggest tool that you have. And you have to be honest with yourself. If you're a very good speaker and communicator, and you think and you get through to people easily, then tap into that positive side of yours and figure out a way that in your short visit times that you can address things that are worrisome to you. But if you're not a good communicator, or you feel uncomfortable in certain very direct situations, use your team. Use your team. Your team may be just your front desk person, but that patient will tell your front desk person far more personal things than they will tell you. And it's just the way it is. And it's not an insult. They see you as the doctor, your time is precious, you're all these things. And the reality is the front desk person's like a buddy, you know. So use the front desk person. Let those people, make sure those people feel comfortable to come to you and say, Mrs. So-and-so's not right. Or this guy's acting strange, he's being so weird in the waiting room, or he's hostile today. Because that will change the way you think of them as you go in, and that's not a bias, that's important. That's important to have. It doesn't mean you're not going to treat or help somebody, but it's communication, it's this unspoken communication. We used to have a picture at the end of our hallway, a dark picture, and I would watch people walk out behind me because they'd come in, you know, and then they'd walk out because it was all done. So, I mean, all different ways of looking and communicating and watching patients are helpful. If you have a hard time saying no to people, be sure you know that about yourself before you start opiates. And transference is a huge problem for all of us, and especially with pain. No one wants to see somebody suffer, right? If somebody comes in, and I have, everybody, you have to figure out what your trigger is. Mine is little chubby ladies on oxygen, because that was my mom. And so when they come in on oxygen and I see them, I'm like, so I have to know that I have to have my guard up against myself, and that I need to not treat that. They're not my mom. They're not gonna. It's very specific. My partner is Alzheimer's. She can't say no to Alzheimer's patients. Sometimes we switch because of that. Like, can you see this lady and make sure you think this is what you would do? And you know, I'm happy to have that luxury. It's not always possible for everyone, but just some ideas for you to let's circulate. Have education materials, because these visits are long. So there's papers in your packet that will help you. There are many online tools. Just to show the CDC put out a great 2 pages that we photocopy and just give to patients on the risk of opiate addiction. It gives you the opportunity to say, here, why don't you look at this? And they'll come back to you. They can bring it back and talk to you later. Everything doesn't have to be done in the first visit. For all of you who are in primary care in particular, make your opiate patients, once you figure out if they're going to come back for opiates, a separate appointment from hypertension, GI, from everything else, because it takes more time, and you're not really given enough time. So it may be that for some patients, before you can do all of this, it's 5 visits, but in these 5 visits, you're going to kind of put together some of the things that we're talking about so that you can be, you know, in compliance, and if you were ever to be audited, there's certain things that are really looked for. I put these up here, and it's kind of an odd time maybe, but these are things that I've said. It's difficult to say no, and these are a few ways that I say no. When I have patients that come and they have been on opiates for an inordinate amount of time, and I don't know why. I mean, well, I was in a car accident in 2003. Okay, but you're okay now, and I saw you bop in here, and, you know, what does that mean? You know, some of that is that it was a horrible accident. We weren't there then, and that person may have taken a year to get better, and they're never going to forget that. But we have to help them move along, and so if they don't have a reason to be on opiates for a long time, I'll say, when was the last time your liver had a rest? It's fascinating how that matters to people. They won't think about that at all. They think about their kidneys and the NSAIDs. Sometimes they screw up Tylenol and kidneys, and they think that that's part of it too. But when you say that to them, some of the people, it resonates with some people that you wouldn't expect. When I have people who are doing things really wrong, when I get a urine that has cocaine in it or heroin, and I'll say, you know, I can't write for these medications, you wouldn't want me to compromise my license. They don't care about my license. It just puts them on them. They won't say, I don't care about your license. They rarely will say that. I've had a couple people say a few choice things to me. But that in general, that's a good, you know, step back, especially for, you know, and I hate to pick on my family practice and internal medicine doctors, but I feel for you guys, because when everybody else says no, they come banging on your door, right? And so you're the end game of all of this. And that may be something that you would need to say or want to say. And it's fine, you know. You don't have to give anybody anything that you don't feel right. You wouldn't give somebody an antihypertensive that wasn't going to work. So if you get a person that comes in with something that's completely inappropriate, then, you know, say no. And feel empowered to say no. I had a girl come in to see me. She was 28 years old for my PM&R group. And my 28 years old, 20 milligrams of OxyContin twice a day and Percocet for breakthrough. For, wait for it, plantar fasciitis. So I said to her, and I could tell, I could feel the edge, because she was bound up in this. She knew she was coming in to see me. I was a new doctor to her, and her doctor who had been writing for this, I think he was a family medicine doctor, her primary care doctor. And I said to her, wow, I said, well, I lived in Florida, and that's what they do there. And I was like, okay, that's fine, I understand. I said, well, you know what, let's make sure that you have the plantar fasciitis. I said, there are some other ways to treat this. And I could feel the hackles going up. And I said, I want to give you a little, I said, I gave her the first prescription, knowing full well that there wasn't going to be prescriptions after this ongoing. I said, let's find out for sure whether you have it, and let me talk to you about some other things as we go. So giving her the first prescription helped her hear me, because otherwise she wasn't going to hear anything. When she came back the second month, she was even more tense, because she probably knew I wasn't going to keep going with this. And she did have an appropriate urine, by the way. And I said, this isn't how we treat this. I said, you're 28 years old. Where do you think this is going to go? And people think that, I said, you haven't thought about this, but what if you fracture something? Or what if you have your gallbladder out in 5 years? When you're in the hospital and you've been on this level of opiate, you're not going to have pain that can be controlled. They think that there's this magic, IV that's going to knock out all the pain. And the reality is, we all know that's not true, right? So I said, you're going to be in trouble. You're setting yourself up for trouble later. She had never had physical therapy. She had never had any cortisone injection. So we got her to a podiatrist. She never came back because she didn't want to hear it. But I'm not going to propagate it, right? So it was a failure, I think, from one perspective, but it gave her food for thought. And somebody has to say it, right? And so it was a pain. It was an intense conversation. But that's the way it goes. The last one is something that I think is important for your young people. Your young people who go to surgery and really do have a bad problem, you have to say this to them. You have to talk to them about what it means to have big surgery, a lot of need for medication maybe up front, and that in a reasonable time, you will be off of this medication, because I'm not going to let you become a drug addict. You'll see as we go on, the young people, particularly post-traumatic people, they are a lot of the people out there who can't get off the medications. If you listen to people's stories, a lot of it started around a bad injury. I had a young girl come after the prom, all hair done at the salon, pulls out and gets completely walloped in a car accident. And she had a degloving injury to her foot and her leg, her lower extremity, and all kinds of broken bones. And she came to me in an external fixator with just this horrific degloving injury, and the wet to dry, all the changes, and the nurse would come into the house, and she was 18 years old. Her mother and father came on the first visit. Her mother was very intense. The girl herself, and I walked in, I'm thinking, oh man, this is a year of recovery for this kid. She's young. She's a lot of loss here because she wasn't able to finish school, the end of her high school, with her friends. And I said to her, we're going to be really cautious with you. And I said, and what was happening is the orthopedic doctors were giving her 5 days of pain pills at a time. So she kept showing up at ERs looking like a drug addict. And I said, you can't give somebody, you can't tell somebody to take a pill every 4 to 6 hours and then not give them enough pills. So I get where they're coming from, because they probably didn't want to give, this wasn't their long-term goal, but then hook them in with somebody that can treat them the right way, make a phone call. So she didn't have that physician-to-physician meeting, and so she was going to ERs because they didn't know what to do with her, the family. And so what I said to her is, no more of the, don't write prescriptions that say 4 to 6 hours. Don't do a range. Patients will get you on that range, and that's not what you really mean. It's not what you should mean. If you want them to take it 5 times a day, take it 5 times a day, and put date times down, or write TID, BID. But don't write a range, because if you write a range, they'll take it on the low range. They'll run out early, and then they'll say, well, that's what it says, and they're right. So it makes it muddy when you're trying to make sure people are taking the correct medications. We're all away from the range on prescriptions. If somebody takes, I have people that'll take 1 extra pill 3 times a week when they're working, and I will give them 3 pills a week extra. and it's a really weird number, but I don't give them a round number because I want to know how much they're actually taking, and it limits it. So this girl, her mother was hostile. Her mother was out of her mind at the end because she said, you have to make her pain-free. I said, I can't make her pain-free. I won't be able to do that. I said, but what I'm going to do for her is make her reasonably comfortable for what she has to go through. I said, and it's going to change because she'll go back to the OR multiple times, and her needs are going to change. I explained to them when the nurse comes for the dressing changes, which is painful when she has when the fixator came off and she had to go to therapy, how to take medicine ahead. And I gave her exactly enough. I added on gabapentin at night in particular to kind of, first of all, right away just to chill her out and help her sleep, but also then over time to give her some pain relief. And the mom was hot. She was furious at me. This isn't right. I said, look, I understand this is unfair. There is no way to make her completely. And I said, I can't let you come out of this in a year with a monkey on your back that you didn't bargain for. And I said, we never know who that's going to be. So let's just, she's only 18. She's got a short lifespan. She wasn't a kid that had been in any kind of trouble prior, but you don't want to set them up. So in the end, the mom never came back. The dad came back for a little while. Then the girl came herself because she was 18 and she could. And you know what? She did beautifully. She heard the conversation from the beginning. She was set up from the beginning to have care. I said, I'm not going to change prescriptions in between. When you have surgery, your surgeon and I will talk. I'll know what you're getting done, and we're going to change things as we went. She was excellent. Within 11 months, everything was done, and she wasn't on any medications. And she went on to finish her, she got her degree, high school education, and then she went on to college. And I feel like for her, it could have gone very badly. And this one time, it went very well. So in your office, you have to make sure that you have a plan, right? So make sure that you have what you need to write for opiates for your patients. Make sure you know something about them. And if you don't, it's okay to take time to figure it out. But just keep it in the back of your mind. Have this running list of things you need to do for the opiate patient. Have your schedulers have a script that will describe for the patient what's going to happen that day. You're going to come in, we're going to go over your records, whatever it is that you decide out of all these massive recommendations, whatever works for you, make sure you have a urine drug screen policy. You absolutely need to do a urine drug screen at the very minimum once a year. That's a minimum. I think random urine drug screens are great. I think it's tricky to remember to do random urine drug screens. It's a little confusing. Some places will take a urine on people and will throw them out on certain people. So there's lots of, not everybody that gives a urine will have it actually sent out, but then they never know when it's getting sent out. So there's lots of different ways to decide a policy, but pick a policy, whatever it is. It's going to be every 6 months on a person, and have your scheduler or your MA flag that chart so that you know this time they need a urine. You don't need to stand there and wait for the urine. Have someone in your office get the urine. Make sure when the person's there that they seal it in front of the patient with their name and date. That'll help you later. You need a cannabis policy, an alcohol policy. You need an opiate agreement. Those are the big four. If you don't have them, you really shouldn't write opiates. It doesn't have to be. You just have to write the policy once and follow it. An opiate agreement is 100% necessary. The alcohol policy is sort of an interesting one, and we can get into that a little bit more later, and all these others. Use the screening tools. If you don't have a psychologist that can help you, use the screening tools that we pick one of them and just use it. The PHQ-9 is a quick and easy thing. It'll help you triage patients fast for yourself. Safety. Make sure that you stay safe in your office when you start taking care of opiate patients, and if you're going to change your practice and you might wind up saying no to people, your safety is going to become paramount. In some of our offices, we have panic buttons, if that works for you. If you have a high population of opiate patients, train your staff to deal with angry, volatile patients. Know a little bit about who you're giving things to and who you're stopping and when you're going to stop, because you may need a little more support from a safety perspective. We have 3 offices. Our one office is the only, we start everyone in one office for opiates because we have security that's better. The other offices are much less secure, and we don't want to wait for a 911 to come. We have panic buttons in every office, however. Exam room safety, which I think you probably should already know, but don't let a patient get between you and the door. So set up your exam room. And you may have one room that's better for, you know the people who you're worried about. So identify them and treat them slightly differently for your own safety. The team approach helps you with safety. When you listen to the people that work with you and they say, so-and-so's agitated today, or this is what's going on, that is important information for you so that you can really figure out what the right thing to do. Sometimes we leave a door open when people are really out of their, intense and out of their mind about whether or not they're going to get opiates again. And like I said, to use your people in your office to help you stay safe. I am saying this on my high and mighty throne, and I very recently didn't do this after many years of taking care of patients. And I had a new office that was like an L shape with the doctor's office on the very end of the L with no escape hatch except out the window. And I saw a gentleman who had herniated his disc. He was an OT for one of the assisted living. And his behavior, his response to the herniation was so aberrant. Truly pain, good-sized disc. I really thought that he would end up in surgery just based on how things were going for him. I had injected him, and he did well, and then as the pain returned, he was like, So when you get people better and the pain returns, it's like 10 times worse because they got a break, and now their fear and everything comes back with it. And he was sweating and shaking, and he was running out of medicines, and he was just a mess. And I said to him, we're getting now to the point where we're giving you medicine for longer than I would like to. We might have to make a decision, like get a surgeon involved in this because, let's at least hear from a surgeon about what we're going to do. And of course, it was a Friday, and there he was, a mess. And I said, but look, I'll give you what you need now, but know that we have to make a decision because he was really waffling on seeing any other physicians. And I'm like, look, you're not getting better. You're a young guy. You're not getting that much better. And he talked about losing his job. And I'm like, let's not lose your job. Let's get you what you need. At least get an opinion. So he left, really upset, but getting what he wanted, what he needed. And then I was sitting everybody left, and I was sitting in my office answering questions, phone messages and stuff. And I look up, and here he was in my doorway. I was like, oh, man. And I'm sitting there, and the desk is too big for the room. And you have to go around the desk, you have to do one of these, and here he is in the doorway. And I'm like, oh, and no one else was there. And I thought, this is it. This is how I'm going to go out. And I'm looking at him, honest to God, looking for a gun. Because he had one of those dry fit tracksuits on, and I'm looking to think, where's the gun? Because he was shaking and doing all this behavior, and I'm thinking, why did I do this? My dog is going to miss me because this is it. Here we go. Everybody else might not realize I was gone for a while, but the dog will know I was gone. So I said, Michael, what are you doing here? And he's like, the prior authorization didn't. I'm like, oh, of course, the prior authorization makes everybody crazy, right? I said, okay. I said, listen, I've got this. I was dying inside. I said, I've done this before. I said, the prior authorization, this always happens. This is what I need you to do. Go back to the pharmacy and wait there. I'm going to send everything over. It's going to be taken care of, which it was. But it also was like, he's like, oh, okay. And then he left, and I'm thinking, I was right behind him and locked the door. I was like, I couldn't have believed what an idiot I was for patient safety. So now that door has a swing on it and a keypad, and, now it's like breaking into the, Federal Reserve. But, my bad experience could have gone really bad, right? So here we are. And, I work very close to, if you remember maybe a year or two ago, the physician that shot a patient in his office. And that was awful. But the patient pulled a gun on him. And his office is like this small, tiny. So I'm sitting there with that in my head. Also, I watch way too many serial killer movies and things like that. So if you're going to start taking over chronic opiate therapies, there are a lot of things that you need to worry about. If you're lucky to get somebody who's never been on anything, that's the best, right? It's all you. Start fresh, be clean, and do things, assess them, make sure you know what the diagnosis is, make sure they don't have a lot of other comorbidities. If they do, kind of put them on the side so that you can think about them. You'll never address all of them in the first visit. Nobody will. But come back to things if you think they're not getting better. Are they sleeping? Do they have other issues? The big problem is when you inherit the patient who came from Florida and the records are all jumbled. And that's when you really have to start from the beginning. And you may wind up giving out some prescriptions that you're not overly comfortable with at first. Document it. You're not going to get into any kind of hassle. Document it. The patient came to me, inherited by another physician. I'm working on XYZ to figure out the problem. No one's going to ding you or blame you for giving a prescription out to a patient so that they don't withdraw while you figure out the process. These are the things that you need to do. I shouldn't have to tell anybody that they need to do a history and physical exam. My friends from the foundation who audit physicians who are in trouble can't get over the number of people who don't do a physical exam. Do something, put something on paper. Lab results. For me, diagnostic and lab results, maybe people have Lyme. Maybe they have rheumatoid arthritis. Look at their pain pattern. Figure out what you need. I love to see scans. If I can't get an MRI, I like to see an X-ray. Anything that helps me direct where I think this is going. The best is terrible pain and a completely normal MRI and normal EMGs. That's that's easy on my end. It's not going to be easy on their end, but it changes the conversation. If you can't have it all at once, which is often, then start with whatever you need. Like in our area, Keystone First won't allow patients to get an MRI without a certain amount of physical therapy. So we start with physical therapy on the first visit. Here, you need to do some physical therapies. I have to figure out what's going on with you. So use what you know about your insurance companies. Give the patient some objectives. Tell them set it up. Set up what you're going to do and what your objectives are, not only what their objectives are. Their objectives are very important. We call them goals. Your objectives are your treatment objectives. Talk about the risk. If you don't have time to talk about the risks, get that paper from the CDC and print it out and say, here are the risks. I want you to look at them. So the next time if you see me, you can talk to me about that if you have a question. Informed consent's kind of an odd thing. That's really here just meaning that you are honest with them and that you give them a little bit of an information. Lift some of these statistics that we've shown you already about what happens to people over time with opiates and about opiate use disorder. Always document the medications prescribed. If you're using an electronic record, it's hard not to. And look over these people. When they come back, maybe the next time they come back if they're stable, but in 2 months, look at them again and make sure it's still the same problem. Make sure you set them up with goals and expectations that are appropriate. So I have an older guy who has arachnoiditis. Arachnoiditis is a horribly painful scarring of the nerves in the cauda equina, and it's a rough treatment. He's an older guy. He's not a spinal cord stimulator candidate for a lot of reasons, but that would be a great way to try to help him. And I said to him the other day, what are your goals? I want to be pain-free. I said, Jim, how long have you known me? You haven't been pain-free since I've been taking care of you for like 5 years. I said, let's get another goal. Well, I want to work in my wood shop. Perfect. When do you take your medicine? He's my only patient that takes half a Percocet a day. I'm a pain doctor. I see patients take all kinds of stuff. I'm not going to get hooked on that dope. I'm like, can you try some of it so that you can, because he comes in and he's miserable, but he won't take the medicine. So even just setting up the goals brings you to other parts of your treatment and it will help you be better. So asking them their goals. And like I said with the girl whose mom wanted total pain control is a farce, right? Pain doctors, we're slackers. We're the 50% group. We are just trying to get people 50% better. In any other specialty, 50% would be abysmal. In our specialty, if you're over 50%, we're like celebrating. So make sure that you are very realistic. If you underpromise and overperform, you'll be a superstar. But if you overpromise and you fail them, then you've set them up for all kinds of problems. Here we are, which is exactly what I said. The goal is not going to be 100% analgesia. There is no such thing as the opiates curing anything. As soon as they wear off, as well as I know, it's going to come right back. And that's what I say to patients, particularly who are not necessarily interested in trying antineuropathics. I'll say, look, these medications can actually change the way your nerves function and maybe solve some of this problem. The opiates aren't going to solve the problem. They're just going to quiet it, maybe, for a little while. Some patients feel that they can feel all the pain through it, so they don't think it works at all. But some people are just afraid not to have something. And that's legitimate, right? Opiate agreements. Opiate agreements, goals, and expectations all can be the same discussion. I have an opiate agreement that I love. I didn't have it up here because I don't think it's in your packet. I'm happy to share it with whoever wants it. Basically, in a nutshell, we took all of the things that we've learned over 18 years, all of the excuses we've had, piled them into one document, and we put names on it. So we're not going to fill your prescription in between visits. You're going to get a monthly prescription unless we are very concerned that you're going to take all of them at one time. If you are concerned that a patient's going to take 90 or 120 pills at one time, you need them to see a psychiatrist with you. So don't forget that piece. Seeing somebody every 2 weeks for opiates, that's a mistake. Give them a month of time so that you can kind of figure out where they are. We give them a calendar, write down when like a page off of a calendar, write down when you take them. It does help out a lot, actually. We will not replace or give back or honor any stolen prescriptions. We used to. When I was at Jeff, we used to require a police report and blah, blah. No, the police were like, what are you doing sending these people to us? I'm like, you know what, enough. We're not going to do that anymore. We haven't done it in years. We had a rash. In 1 week, we had 2 or 3 women who were putting their pocketbook on top of their car, always at Walmart, which is odd, and their pocketbooks were stolen and their medicines were gone. What is the likelihood? I mean, really. So we're like, that's a shame. Hang on to your pocketbook at Walmart. Don't put it on top of your car. I actually tell patients that as a joke. I'm like, please don't call me and tell me you lost your prescriptions from your pocketbook being stolen. I had a lady just the other day who was pulled over by the police. I don't know what she was doing. Maybe she ran a stop sign. She wasn't clear. And her prescription that my partner had given her, my partner was on vacation, right? That's always a favorite. And it was Friday, so it was like the triple whammy. She takes her pills out of the prescription bottle and puts them in a blank prescription bottle because she doesn't want anybody to know she's taking them. And she's got the prescription and the pill bottle on top of her pocketbook as she's driving around. So who does that? Like, that's odd, right? And I'm like, The police pulled her over and took both of those items, according to her. I'm pretty sure that never happened. The story changed 3 times because my PA took the first message. Then it was like, well, the pills were on top of my bag. I'm like, I said, well, you know what? I have to tell you, as a policy, I didn't know her. I said, we're not going to fill these. What do you mean? I said, we're not going to fill the prescriptions again. You're responsible for your prescriptions. My partner won't fill them either, but she's not here. And I said, if I did this for you, I would be breaking our policy, and that's discrimination to other people. So if you don't treat everybody the same, you're discriminating. And you know what? I don't know her. And guess what? She didn't withdraw. So I guarantee she found them. She also, when my partner came, I said, you need to make an appointment with, but we're not going to get your prescription filled ahead. So we know the dates. This is when you're out. And guess what? She didn't withdraw. So I can tell you right now, she never lost her prescription. So, be very specific about your boundaries. And don't feel bad about if you tell somebody up front, it's all well and good. It's a contract. If they break the contract, there's your out. You can choose to be out. You can choose to say, I'm going to give you another chance because, hey, I've had my little old lady. Why is there Vicodin in your urine and we're giving you, something totally different? Oh, when I went to a wedding, I forgot my pills and my friend, people are very happy to just take a pill off of any other person and just take it. So they're very trusting. I mean, I'm like so jaded that I'm not trusting at all. So anyway, so that happens, right? These people that are nefarious will show themselves to you. So you don't have to be like, I got you this time. It'll come out. But be very upfront about what you want from the patients and what you're going to do. And that's the use and so I think that the contract and the goals and expectations, that can be all one conversation. The PDMP, you all know that whether you write for opiates or not, you should be registered for the PDMP, right? Is everyone registered? Okay. You also should audit the PDMP and make sure that whatever you've written for is what you've written for and that somebody else you're not getting assigned other people's, either patients or drugs. It happens. The system's not perfect, but it's helpful, right? And so any patient that you're about to give, I would argue if you're going to give them a benzo, you should, or an SSRI, you should look at what else they're taking. And not everybody's forthcoming, so the PDMP really gives you a different look. You don't have to be the one to do it. You can designate a user. My office, I get it printed out. It's sitting on top. It's there for me as I go in to see a patient, so I know what the last is. It's a great tool so that when somebody says, "Oh, I need something for pain," you say, "Oh, well, I see that your primary care doctor gave you something. Oh, that's perfect. You have plenty to cover you for this. You don't need it." Oh, yeah. Oh yeah, use that. And maybe if you use it all, then that's your problem. But it's a teaching point for them. They learn, right? If you allow bad behavior, you're going to get caught in a loop. But if you're kindly strict about it, you'll be able to clean up some things that maybe aren't perfect. So you want to make sure you document the risk. These are getting repetitive, but you can see confirm the diagnosis. We meet monthly about our opiate patients because we're a pain center. My first thing that I say before anybody gets presenting, I'm like, start with what's wrong with the patient. And we do a pain diagram when there's like a little man, like an androgynous person, and the patient's coloring. I'm like, bring up the little man. Let me see it, and then tell me what's wrong with him. And that way you can always at the center of all of it is, what are you treating? And then who are you treating? But what are you treating is important. Confirm the past opiate doses, which is a great PDMP. You want to make sure this is ADRB, that's aberrant drug-related behavior. Misuse, abuse, substance use disorder. These things are all very intertwined. Get a urine drug screen and check the PDMP. So before you start, take a urine, right? Before you start, get the PDMP and look at that. And that gives you a jumping point. Ignorance isn't a defense for bad decision making. You can't say you didn't know. It doesn't work. So, thoughtful, well-documented use of opiates is often missing. Write down why you're giving it. The patient had a fall and has compression fracture. Awfully painful. Deserves the opiates. Write it down. It's fine. Just say why. We're going to try it. They'll be back. We'll reassess them in a month. This is what we're doing. You know, if you have we'll defer a urine drug screen this time. If the patient needs it ongoing, we'll rethink it. I don't think that anybody that needs an opiate for a month has to have a urine drug screen, but if you're going to write it for more than 3 months, you should make sure you start with the contract and then really let it kick in. You never know which patient's going to turn into the 3-month deal, so have it ready in your mind and then go for there. Go for it. A clinically worthwhile risk is to see a 30% drop in the pain and a 30% increase in the function. So some patients can never tell you whether they're better or not. Just ask them what they do differently. Their spouses, the kids who live with them, they'll say, oh yeah, now she does more, especially in our older population who may have a little cognitive impairment. They'll say, oh yeah, well, she seems like she walks better and she's not as sad looking. That's functional improvement for somebody who may not be able to tell you exactly what's better for them. Urine drug screen is a huge topic. Use of the PDMP, opiate dosing options. Let's talk about the urine drug screen quickly before we give you guys a break. The urine drug screen is your window into what's been going on. Identify somebody in your practice to have them take a urine drug screen on the first visit that you're going to embark on what you think is going to be a longer type relationship with opiates for the patient. It's better for it to be unexpected. When you do it, standardize your collection. So the same person or persons take it, that in front of the patient, they seal it with this is your name, because later on you'll have to rewrite history if you don't have that done. If you know every time your MA or whoever, or a nurse in your office, whoever you have, if they do this the same every time, then you'll feel confident when the results come out odd. Document your results. Have somebody give you these results ahead. It takes, in our area, it takes about 10 days to get a urine drug screen back. So we'll see them, get a urine drug screen. The next time we see them, you're looking back in time when you talk to them. Unexpected results will help you. When you take a urine from somebody, ask them, when was the last time you took your pill? If they say, oh, I took it last night. 10 o'clock? Yeah, 10 o'clock. Did you take it this morning? No. Yes, no, yeah, I did. Okay, you took it. Document it. Write it down then. Have a template in your EMR that says this, so that the person that takes the urine can fill this out. Do you take benzos? Do you take, because they don't always tell you, oh yeah, I take it once in a while for anxiety. Did you take any? And then we ask flat out, illicit drugs, heroin, cocaine. I know marijuana is not an illicit drug anymore. We always ask about that. When people don't tell you, that tells you something about them, okay? If you don't ask the question, then you have nothing to go on. But if you've asked the question and they've said no, then you have a different conversation. in your mind, or you should. If a patient says, yeah, you use cocaine and heroin, you say, well, that stops the conversation there. I don't even need a urine at that point. I need to say to him, okay, we're pivoting now because your discussion isn't about whether you're getting opiates, because you're absolutely not getting opiates from me. The discussion now for you is about do you want treatment? Because no one's getting heroin and just coming off of it on their own. So, and in your packet, by county, are the centers for you to help people go to for help, for addiction help. Because in different parts of the state, there's less and more resources. But by county, in that packet, there's the people here at the Pennsylvania Medical Society put down a really good list for you guys. These are the medicines that you should, these are the time window that you should realize, and we all know pot takes about 30 days, which was always very helpful to us in pain medicine, because in our area, it was a gateway drug to other things. It helped us know where the patients were. Now this is going to become a little fuzzier as time goes on. CBD oil, by the way, comes up in the urine drug screens. So you need to ask that question separately. Cocaine, 2 to 4 days. Opiates, 2 or 3 days. Methadone, very variable. Benzos, days to weeks. Alcohol is the worst one because it's so variable. You can have a beer on Saturday. It can show up on Tuesday in your urine drug screen. Alcohol policies are important. We will allow people to have a couple times a year, twice a year, an alcohol positive urine drug screen, and then we say, you do know that these are dangerous together. Certainly people probably drink and take benzos, and the problem is they're taking benzos, alcohol, and now they've got your prescription on top of it. Now all you need is a hot tub, and you've got like an E! True Hollywood story, and your pills will be on the side, and you'll be in the newspaper. So I think that the key in all of this is to make sure that you have the discussion with somebody. I said to my partner, and we went a couple rounds over this, when patients have alcohol in their urine, like she had a patient who was consistently coming in. I said, this guy, you got to tell him to stop. He has to stop, or you're going to stop, because together this is bad. Well, I mean, he just has a couple glasses of wine. I'm like, if you told my husband that he needed to stop drinking wine if he's going to take this medicine for his foot pain, he would stop drinking wine, or he wouldn't take the medicine. Like it's an information for the patient, but it's also important to realize, like, do you want the medicine? Do you think it helps? Because if it doesn't help, that's fine. Have your wine. Maybe that works better. But you have to really be defined. These are the pathways, and it's important to know some of the pathways for metabolites, because you should see metabolites in patients who take the medicine consistently. If your patient, and I have many patients like this, who take it 3 times a week or periodically, then you won't see the metabolites necessarily, and it doesn't mean anything. But if you have a very high dose of the parent drug and no metabolite, they took it before they came to your office. So you have to wonder, where are all the pills going, right? And I'm in a very jaded position, so I'm always sure that people are selling it, But that's because that's how it's gone for us. In your area or in your group of population, it may not be like that, but at least it'll tell you if they're being consistent. When there is no morphine and no parent drug, look to see if it's being tested at the lowest possible level. All of your urine drug screens, just to avoid the hassle and the extra phone call, always ask for them to look at the lowest detection level. That will solve all the questions of, was it there, wasn't it there, is it over the number of millimoles or whatever. So just have them do it low. It doesn't cost more for them to do it low for your patient. And at least, if they don't have it in there and they said they took it, they didn't take it. No one's that fast of a metabolizer. There should be either the metabolite or the parent drug. I mean, we don't ding people for having high parent drug and no metabolite. It just sets off a bell in our head. It doesn't mean that you're not going to get your medicine. It means we're going to keep our eye on you. And your name may wind up in our opiate meeting faster than somebody else's name. Here are the metabolites in the bottom. I'm 2 minutes over for the break. And they're in your packet, so you can have. I mean, I like this little list so that and most of the urine drug screens will tell you this is a metabolite of that. But just so that you know, don't panic when you see hydromorphone. It doesn't mean that they're taking it. It's your Vicodin breaking down. So the first time any of us have ever looked at urine drug screen, it's like, oh my God, they're taking it. Somebody's giving them Dilaudid. No, it's the metabolite. It's supposed to be there. So. Document, ask what they're taking, look at the PDMP, make sure you're aware if there's any aberrant drug-related behaviors, and hopefully you'll be able to start with that to begin your evaluation and your process for treating these pain patients. One of my internal medicine colleagues came up and just asked about poppy seeds showing up. Poppy seeds do show up if people eat them. We had a guy that liked everything bagels every day, and he didn't know about it. Now, some people, like my friend was saying, some people know, and they're like, oh, I eat poppy bagels. But this guy didn't know, and he came up positive, and my partner said, hey, tell me what you eat every morning. What do you eat in the morning? And then it was like, then she found out without saying, do you eat poppy seed bagels? So, it's all on how you twist it. As I said to the doctor in the back, I said, listen, the bottom line is, we're not detectives. Despite all of my CSI stuff that I love, that's not our job, right? Our job is to make sure we're documented properly, give patients what we think they need, and figure out over a few months, they will vet themselves. They're not smarter than you. You're smarter than them. If you have policies in place and you follow your policies, if you have somebody you're unsure about, skip a urine drug screen. So we do them every month because it's chaos if we don't. But suppose you were doing them every month and then skip a month or two. Now the person thinks they're not getting it, and then do one. It will tell you a lot about them, especially if you're nervous about somebody. So if you think, if your little hairs on your spine go up about someone, change your practice a tiny bit to see what comes out of it. You're not held responsible for people lying to you. You do everything in good faith. The guy that has the high opiate content in his urine because he took the pill coming in the door, it's there. I'm not going to be able to prove that he did or didn't. I don't have cameras on him. And that's a waste of your time. Just know, okay, I've got my eye on this guy. Something's up. And you pay attention and vary it a little bit and see what happens. Another thing that's not on any of these slides, but it's good to know, when you treat couples, give them different medications. Give them different opiates so that you know if they're sharing. There are many couples who come in and one person is getting pills for the other person who actually has a problem, or pills for the grandchild, or their kids, or whoever. So in your mind, these are little things. Listen, I just want to take just 1 second to when I was in Villanova doing this lecture, the primary care doctors were honestly concerned and legitimately. This is all these things that we do in our practice that I'm telling you about. This is for you to know what the standard is. This is for you to know what good ethical pain management. We all see the guys going to jail. I don't know what's going on in Montgomery County. They're getting nabbed right and left. Get yourself connections with people who are reputable, who are ethical, because this business of opiate management is really fraught with a lot of bad behavior. So I'm telling you what ethical people do and what the standard of care is in big pain centers who have really thought this out. Not perfect. Not a perfect situation. You are not going to be able to do all of this in your practice. I know that. That's not the point. The point is to show you the big picture and for you to select out the things that are going to be helpful to you and to know when it's time to say, okay, so I'm not getting anywhere with this person. If you send somebody to a pain physician, you should expect a letter back. If you don't get a letter back, have somebody in your office call. You should have a patient, when the patient comes back to you and you look at the PDMP and Dr. X is giving them Percocet, a letter, you should have a letter somewhere that says this is why I'm doing what I'm doing, if they don't ask for it. As specialists, we are required to send you a letter to the referring doctor. It may be that, the eFax thing's jammed up and nobody knew and nobody cared, like it's, out in, it's pixelated in the air somewhere. So just make sure you get the information back. A lot of times our primary care doctors will send somebody and say, can you just tell me I'm doing the right thing? And we go through most of this stuff and say, yep, if you have any changes, send them back in 6 months. But it gives you an insurance policy. It gives you that reassurance that, hey, I've got this down, I'm doing it right, I've got, other doctors that are agreeing with me. That's a fine way to use your pain doctors. These are some red flags. I don't have to go to the bathroom. This is for patients that want medications. If you don't produce urine, you don't get your prescription. I had one lady drink 8 bottles of water. I was just going to burst. She's going to get diabetes insipidus in my waiting room because she was I'm like, how is this possible? We've learned with a few patients that they do take a while. They don't get an appointment after noon because they got to start at 8 and drink 10 gallons of water. But this is how it goes. check your urines and make sure that they have the correct specific gravity. They'll tell you on the reports, so that no one's putting water in your urine. We don't do this. It's not a chain of custody like for the courts. You don't have to watch them. You don't have to turn your water off in your bathrooms. You know, this is a different level of why we're doing this. The doctor left the practice and isn't available. Okay, that can happen, especially when people switch states, especially when people are getting arrested. So my friends in Montgomery County, who I don't know, but are clearly in big trouble, their records are going to be, no one's going to get those records. And we've had the people calling already. No records, hard to say. It makes your job a lot harder. Doesn't mean you can't see them. It's just going to make your job a lot more tricky. My doctor only gave me enough medication till today. That's the worst, right? I got, my last pill is today. And, you know, I used to get so twisted about that. I get that wait times make this kind of difficult. If you have a good relationship with a pain practice in your area, learn what they do. In our practice, and like I said, and this is pie in the sky for many people, the first visit is with a social worker, our master prepared social worker who does an opiate risk assessment, and we do a urine drug screen with all those questions I asked you about time and when they took medicines. The second visit is either with a physician or a PA, usually a PA just for flow, and we get the medical records and we do a physical exam and have everything in order so that we can then as physicians go in with all of the information we need. So it's 3 visits in our practice before a patient gets a prescription from a physician. There are no prescriptions before that. Those patients have a letter when they come in. They're told by the scheduler. If they have an address, I was just telling one of the other doctors back here, I work in Chester, and if you know the area, it's you know, a rough area at times. It's a lot of you know, underprivileged people and some lovely people that have nothing and some people who are really, you know, criminals, and it is what it is. I also work in an area that's lovely, that's a Chad's Ford, that's a you know, a nice little community, and the patients come in with like 10,000 lists of things they've come off the internet with. So I've got a real dichotomy of people. You have to make sure that you are watching the patients that you know, the last pill is always a trick, but you know, when people tell you what they want, either they've been through the system and they like had a liver transplant or a pulmonary, either they're really educated patients, right, who are not nefarious, and you kind of, even though it may make everybody's like, you know, ego bruised a little, well, I know what works for me, you're like, okay, calm down, but they may know what works for them. And so you almost have to like put your, like, it's abrasive when people say stuff like that, but you kind of, now there's other people who walk in and they're just like, this is the only thing that'll ever work for me. And you're like, okay, you're a different person than somebody who has literally been through the system and knows a lot about their own medical care. And you'll have to figure that out. People who leave the initial visit and forget to give the urine or give an inadequate sample, that you'll know before they even hit the door. And people who come in, and it just happened, it was perfect. I said this to my partner. Friday afternoon, young guy comes in with his girlfriend, 2-month-old infant in tow, terrible pain, last pill, you've got to fix this, I'm going to get into trouble. That's a giant red flag. You can't, you know, somebody else's urgency should make you step back. Never feel that you are absolutely, if you have not written a prescription for the patient yet, it is not your responsibility to write an urgent prescription for chronic pain, okay? And so it's awkward and it's uncomfortable because most people are pleasers. Step back and like look at the situation and say, okay, this guy had thoracic spasms and a clear MRI, and he was like 30 and sweating. And you know what it really in the end was? She thought he had a lot of anxiety. I think he was withdrawing. He said he took his last pill that morning. We don't know that. He could have taken it 3 days ago, and that's why it was so darn urgent. I hate to think the baby was a pawn. It may not have been. Like I said, I'm horribly jaded, right, to think that they're bringing a baby in. But it's, you see a baby, you see a young, you're like, take a step back. Anybody that pushes you hard, you have to step back and pause. What do you want to prescribe? What do you want? Opiates shouldn't be given to people in a vacuum for chronic pain. So you need to think about what you want to prescribe. Do they need physical therapy? Should we use other medications? Are there some self-management therapies that are helpful to these patients? Are they on benzos? Benzo's a hot topic. You know, after the opiate crisis, the benzo crisis is going to come out next. Be cautious. Benzos are dangerous, and they mix badly with some of these meds, and people seem to be on them, and they take them indiscriminately. So stopping benzos, as you know, is very dangerous. Stopping opiates is uncomfortable but not dangerous. Stopping alcohol is dangerous. So benzos and alcohol, that withdrawal is really worrisome. The alcohol, the opiate withdrawal is uncomfortable. We'll get into that. Initiating treatment. So like this is redundant, right? So you have your goals. You want to make sure they don't have adverse. The AE in this slide is adverse effects. Okay. So you want to start with some goals. You want to start low on people who have never tried anything before. You want to make sure that you think in your mind, is there anything else going on with this patient from a psychiatric or point of view or a sleep point of view? And do they actually have history of aberrant drug behavior, addiction, diversion, things like that? Some of which you might know, some of which you might not, but you'll have in your mind, you know, over time. You should, in the old days, we were very half and half about how we did this. In general, you're better off starting with a short-acting opiate because you can get off of it easily on people who are opiate naive. Long-acting opiates, especially in elderly people, can be longer than we think. So start slow and tell the patient, this isn't going to be perfect this month, but we're going to work on this. And maybe next month, if you start fast, if you respond with too high of drug, you have nowhere to go. But if you start a little slower, you have a place to go, you have some wiggle room, and you can hopefully help the patient not have as many adverse effects. This I love. It's sad that it's at the bottom. Aberrant drug-related behavior, 30% of people in 3 months. So you can do everything perfectly and just watch, right? Even people that you aren't sure about, that you think, and you take a chance on them, that's fine. As long as your documentation's fine, they will show themselves over time. They're not going to be able to hold it together and not use cocaine or not sell the drugs or whatever it is that's aberrant about them or for very long. You'll see. If you're vigilant, it will come up very easily, and you'll be able to tell. If they're getting better and they're doing well, document it. Document that they can do more. It's wonderful. That's a good thing. That's success on your part. The MED is an important number for everyone now. And have you been hearing about the hot topic, the MED? I think the insurance companies might have made this more of an issue for most of us. This has been going on for a while. The guys at Harvard were talking about this maybe 5 years ago when I went up there for a conference. It's the morphine equivalent dose, and it's something that you can calculate. Any opiate should be converted into morphine, and then you look at the 24-hour dose. This is the conversion chart. This is another. So the other one with the metabolites in urine, I cut that one out. I taped that to my computer. This is my other one that I've taped to my computer. Every patient, and you don't have to do this if this isn't for you, but for us, it's a good. You know, when I work with extenders, we've initiated that every patient on opiates has to have an MED written as a one line underneath what the urine drug screen shows. That way, we can look at anybody that are in high MED doses. That means something. And so here we are with oxycodone. You know, you take the whole day of oxycodone, multiply it by 1.5. It tells you how much morphine equivalent they get in a day. These numbers are important because it tells you how the patients are going to do. The MED is greater than 100 is a problem. Anybody that comes to you with an MED greater than 100 should be, the first thing you should do is get them under 100. And we'll talk about some tapering. People that are over 100 MED either have been bounced around a lot, and so or they're on it for many, many, many years. Often there's substance abuse and mental health issues. They usually have pain complaints all over the place. And there's a significant risk of abuse and overdose. It depends. So every patient's different. If they're 100, 120, you can start to wean them. You don't have to wean them fast. You just have to start to wean them. I had a guy come to see me. His MED was 500. And, you know, how long do you think that's going to take me to wean a guy that's at 500? I mean, he was a very big guy, and actually he was, sadly, only 58 years old, and he was living now in like an assisted living at a young age because his size, he had 2 joints on one side that were gone, that needed to be replaced, but no one would replace them because he was, you know, multiple times over normal body weight. You know, he was like a 400-pound guy, and so he just couldn't care for himself on this much morphine. Now, if you're a 400-pound person, what do you think your lung capacity is over time? So I actually said to him, you know, the bottom line is you need to go to rehab. You need to go to alcohol and drug rehab where you can. That way they can bring them down faster. They can bring them, he has to get, I mean, even if they're not going to bring them down to off, bring them down into a range that another person can manage better. And so for him, that was the better way to go. For some people who have high MEDs, like the 120 range, it depends on the person. I had an audiologist come, nice woman, on morphine for fibromyalgia. And I just said to her, 2 kids, like a 2-year-old and a 4-year-old, busy woman, business suit. And I said, you know, this isn't how we do this. This isn't the right diet. How come nobody ever said that to me? I'm like, I don't know. Let's start where we are now. Let's not worry about, you know, it's difficult, right? They have trusted physicians and now you're going to come in and blow them out of the water and tell them a whole different plan. So just say, things have changed. Guidelines have changed. Let's try to get you down. She is actually somebody that I sent for Suboxone, and this isn't a talk on Suboxone, but I sent her to a reputable Suboxone physician. And, you know, Suboxone's tricky because it's cash, but for a person who's working, who can't go to rehab, whose weaning is going to get really uncomfortable, it might be the right way to go in the select patient. You have to be very cautious of who's giving Suboxone out in your area and why. But it's a nice way to kind of help people. When you wean somebody, their receptors are dull, right? So think of the receptors of having been overloaded for years. So the body just says, well, I don't need to make any endorphins. You know, I'm done. Everything's coming exogenously. Well, when you wean them, it takes time for those receptors to catch up. So the patients feel terrible. For a long time, for like 6-8 months of lag, just this malaise. Suboxone helps that. For certain patients, that it can make that malaise not quite so uncomfortable. So I think I send maybe 1 or 2 people a year. The other guy with the huge MED, he went to rehab because there was no way I was going to be able to wean him in any reasonable fashion. And I'm not going to be writing for, you know, 500 milliequivalents of morphine a month for anybody. So, I mean, he wasn't dying. So it's, in the cancer patients, it's a whole different story. And I think the cancer situation actually, as an aside, has gotten more complicated because, you know, cancer people survive, right? They're survivors, and their length of life is different, and so I think they're going to kind of fall into some of this over time. They did a case series, and they looked at effective non-cancer pain, and they found that the vast majority of people were under 40 milliequivalents. That's not a lot of opiates. That's not a lot. And even some of the more recent population-based studies showed that 35 were effective, 35 milliequivalents. That's a very small dose. So just to give you some perspective, when your patients are on 100, they may need, you know, half of that. If you can get somebody to 70, that's a really manageable number. Getting them as tight as 40 or 35, that's tricky. That may be something that you think of for people you are starting naive, that you may decide that that's your threshold for not going any farther and to passing them on to somebody else that maybe can help them differently. In 1996, the MED was about 80 in lots of people in injured workers on long-acting opiates. In 2002, it was 140. No one's looked at 2018 yet. Can you imagine what that number is? Because I guarantee it's going to be much, much higher. So an ounce of prevention is worth a pound of cure, right? So if we can do everything we can do to help these patients and be very judicious in our practice, it'll make them less at risk. We have to be careful to match the risk and what we're doing. So like I said, don't give people extra pills if you're not sure about them. Give them exactly what you want them to have in a month, even if it's a bizarre number. Opiates don't create addiction, but there are definitely genetic, social, and psychological predispositions for some people, and I'm sure you know that just in your own practice. So we want you to make sure that you risk stratify in some way. Do one of these surveys that we talked about, the PQH9 or PHQ2. Get your opiate agreement out there. Put your goals up. look at the outcome. When somebody comes back, are you better, worse, or the same? Can you do more than you did before? You know, the VAS scale, that works for some people. I like it. Not every patient can answer it, but at least you can get a sense. The good news about the VAS scale, it's always on them. It's always whatever they say. Your 7 may be different from your 7, but it doesn't matter because it's always back to the person that it starts with. If they can follow your urine drug screen, follow the PDMP. These things on this, these are the basics, and they're important for you. And this is what's looked at if you were to get audited. So we talked about efficacy. Adverse events, bad side effects, you know, constipation, diarrhea, constipation, nausea, confusion, you know the side effects of opiates. That's easy. People won't tolerate a lot of those things. They'll come off. Aberrant drug-related behavior, addiction, and diversion are all considered adverse events, as I'm sure you know. Measure outcomes, and this is what we already talked about. Is their function better? Are they globally responding? And sometimes I'll say to people, from the time that you first met me, from the time we started doing this, how much better are you? Because it gets granular after a while, and people can't see themselves from before. And sometimes I'll pull up, like I said, that picture of what they color in at first. And you're like, look, you've colored in half of what you colored in when I first met you 8 months ago. So, you know, show them and help them understand whether they're getting better or not. Maybe they are, maybe they're not. These are the definitions of dependence, addiction, aberrant drug-related behavior, misuse, abuse, and diversion. I'm not going to read these to you. We all know what they are. It's not a bad thing to have somebody in your office go over these with patients or distill this down and just give them a definition so that they know the difference. I mean, I always tell patients, tolerance, everyone has. Withdrawal, people that take chronic opiates, everybody has. That has nothing to do with addiction. Addiction and abuse are different, and it's taking the medicines for obviously the wrong reason. Any behavior that suggests a non-prescribed or a non-medical use, and I had a physician come to me who was a hepatic surgeon, a liver surgeon, who worked actually in pharmaceuticals and no longer operated and had a bad back, and came to me and said, I have to tell you, I like the Percocet too much now. Okay, that's easy, right? I mean, it was hard on him, it was easy for me, and it was awkward. You know, here's a colleague. That's a hard, you know, here's a colleague, a fellow physician. And I admired him that he would say it, you know, and I said, okay, well, you have a couple choices. And so he wasn't on huge doses. He was taking 5 a day. He wasn't escalating. He didn't have any of those red flags. He came and said, I'm not having that much pain. I just like the medicine. And so we weaned him. His wife was an OR nurse, and we weaned him over a weekend at home. And he felt lousy, but he did it. And, you know, everybody's situation's tailored to them. And if you get to know them, your patients well, you'll know what to do better. When you think about aberrant drug-related behavior, think about people who never get any kind of relief out of the medicine. Do they have addiction and diversion in their past or currently? Are they treating anxiety and sleep with opiates? Are they losing them? Are they calling you in between? Or are they having trouble with cognitive function? So aberrant drug-related behavior may not be criminal-type behavior. It may be just that the patient's aging and cannot think straight about how to take these medications, in which case it's just not for them. Here they are, which we've kind of gone through in anecdotal in all the stories that I'm telling. Selling prescriptions, losing the prescription, abuse, forging. Oh, we had that. Every one of these things on this list, I have a phone call for. I have a story about, which would take us forever. But these lists come out of actual practice. Borrowing, repeated dose escalations. There'll be patients that'll come in and tell you, I had to take 5 on Saturday. I couldn't take it anymore. Okay, if you took 5 on Saturday, then you have to take 3 on Sunday because you're going to be out. So and that empowers people to manage their own, to understand the seriousness of this. And it'll kind of, we're in this weird spot now where we have to educate patients like backwards. You know, the cat's out of the bag and now we got to grab it and get it back. And one of the ways is to be, as we are strict about this, also educating patients because, you know, they didn't really get the right education at the start. An opiate use disorder is also exactly what you would think. Taking more than intended, not being able to cut back, spending a lot of time doctor shopping, which I think with the PDMP, the doctor shopping's gonna really cut down a lot, or at least you'll know about it better, easier. Used to be that you'd have to wait for the another doctor or the pharmacy to call. Now not so much. People not fulfilling their obligations, and sometimes you'll hear from family members on these kinds of things. Having interpersonal problems, these are a little trickier to find out. Occupational, it depends on your group if they work or not. People being very irresponsible and having high-risk behavior because of opiates, and acknowledging that they have trouble without using them. That's all what an opiate use disorder, or having trouble because they use them. Mood disorders, I mean, can you see this over and over again, right? Mood disorders, poor coping mechanisms, poor family structure, abuse at a young age, high doses of, these are all people that are increased risk. Anybody on these very high doses of morphine. These are all high-risk people that if you inherit them, you need to have extra antenna for watching them over time, and really be very clear with them about where you want to go and what you're going to do for them. There's an association between white men and prescription drug abuse of younger age, patients with subjective pain complaints, multiple, the whole area, somebody who thinks their whole body's in pain. There are, very few honest disorders that your entire body, when their hair hurts them, all those, when their skin hurts them. They're all Waddell's signs, all those kinds of just really over the top. Doesn't mean that they don't feel pain, but you have to start to think if there's other things going on. So risk stratify your patients. You don't have to deny somebody treatment because they're high risk. You just have to be aware that they're high risk. And maybe write it down. They're high risk, concerned about, blah, blah, blah. And then follow it. As long as you write it down and you document your thought process, it doesn't mean that they don't deserve care. If somebody's on opiates and they're not getting better, stop. Go back. You know what? We've done this for 6 months. You're not any better. We've tried this. We've gone up. We've switched to something else. You're not getting better. These don't work for you. Like I said, you wouldn't keep them on antihypertensive that didn't work for a year. So, pay attention to that. A lot of, so patients 18 to 24-year-old males, hate to pick on the guys, but I don't know if it's supposedly more prevalent in males. I think it's fairly equal in my practice, to be honest. Lots of 12 or more opiates, so a year of opiate prescriptions or multiple opiate prescriptions in a year. Early refills, patients seeing psychiatrists, and depression. I think that that select population may need more psychological support, and they may be at a higher risk just because of other comorbid problems. Tapering is, if you asked everybody in here how they tapered steroids off of patients, you'd all do it by like one pill different than somebody else. There is no magic to tapering. Be clear. Tell them how you want to do it. Drop one pill every day for the next week. It depends. If you're on 5 Percocet a day, you can drop one pill every week, right? In 5 weeks, you'll be almost off. If you're on a long-acting and a short-acting, I always wean the long-acting first. And that because the short-acting over time is just easier to get rid of. It doesn't have to be that way. You can do whatever you want, but you have to be able to explain it to the patient. Know when to say no. Sometimes, by the way, tapering does not mean weaning off entirely. It just means bringing them down and see what happens. I'm in the middle of tapering a woman for a primary care doctor who didn't really know the patient and was in over. It's like, I can't do this. This person's not listening. I'm like, that's fine. I can be the heavy for that. And she comes in, and guess what? Her pain score is 1 out of 10 with half the meds that I've given her now, as opposed to 3 months ago when she was on more and had 1 out of 10 with the meds. So she's not worse. So the funny thing about these high doses of opiates is that they cause something called opiate hyperalgesia, where the nerves become irritable. And so we find that even as you drop the patient down, they are not worse, especially when you go from that 100 to 75 or 50 range. They're really not worse. And so you may actually be doing their liver and them a huge favor for other things in their life, but you're not making them worse. So don't be alarmed or worried that it's going to really hurt them. The faster you wean them, the potential for relative withdrawal is there. Malaise, things like that. So, and that's okay. I mean, be careful. We talked about all these things. Don't feel bullied. Know when to walk away. Say no. If you are not comfortable and you have not written a prescription, you're not obligated. You're not. you're not allowed to abandon somebody. That's poor medicine. That's poor everything. But if you're getting somebody referred to you and you don't know what to do with this, that doesn't mean that you have to keep doing it. Now, of course, from the guys that get people coming from Florida and there's no doctors around, you may choose, okay, I'm going to do this, but I'm going to be very specific in my chart and say, this patient is coming from, I'm not going to allow them to withdraw. This is what I'm going to do for now until I figure out more of what's the patient's about. Anybody that threatens you, anybody that stamps out and walks out, they have fired you. If somebody stamps and walks out and yells and curses at you or curses at your staff, good riddance. Good riddance. They can find they're not going to be good patients for you in any way, and they have fired you. If you're fired by a patient, you don't have an obligation. If you fire a patient, you have an obligation. Especially if you are currently writing for medications. But if they fire you, your obligation's over. So feel that one, you know. And if somebody walks out, they've fired you. And you can say, you're going to leave, right? I'm out. I've had it with you. I've had people walk. It's terrible. It's a terrible feeling. You're like, oh my God. It's very disruptive to you. But it's the end. It's the way it goes. Sometimes it's harder to do the right thing. It takes longer. And it's more difficult. Sometimes you'll do all the right things and you will be wrong. And you know what? That's the way it goes. That's medicine, right? You think you've got it all right and you're wrong. You know, withdrawal is about 12 to 36 hours, depending on the patient's metabolism after the last use of opiates. It lasts about 2 weeks. It's not life-threatening, and it's very uncomfortable. And one of the psychiatrists asked me, you know, what do you do when you know they're going to withdraw, like if they lost their stolen prescription? First of all, the lost and stolen prescriptions, they don't withdraw. They did not usually lose them, so don't worry. And I used to worry about this. Early signs are agitation, anxiety, you know, and then they get the flu-like stuff later on. They'll survive. If they are very Gatorade, we don't treat them. You can treat them with medications like clonidine and things like that, but we don't actually treat people who are withdrawing. We usually help people withdraw with taper so that they don't withdraw, but in general, we haven't had a major problem. If people are really playing games, they have other ways that they can get medications so they don't withdraw. They're much smarter than we are with regard to this. I would taper people that don't know what they're doing, that are continuously or repeatedly messing up the prescriptions, and it's unsafe. And that's the second, especially the people living alone with decreased cognition. If you think people are getting meds for all of these things on this list will come up if you watch your urine drug screens, if you follow the PDMP, if you figure out what the actual diagnosis is, you'll figure out all of these things. There's a PEG scale that shows patient, and that's in your packet, actually, that shows people's activities. 3 questions. It's an easy way for you to, if you're treating somebody for a few months with opiates, give them the PEG scale. See if they're improving. It's quick. It's a quick and dirty way to get a sense of whether they're getting better or not. Tell them, you know, hey, I don't notice a lot of change. You know, maybe this isn't working for you. Sometimes they'll get better just by saying that. Sometimes they won't. But it's a way to help you kind of gauge if you're struggling. Always taper when somebody asks you to. That's never something any of us have a hard time with. Keep people around that 50 milliequivalent morphine per day, especially when they're on benzos. Be wary that even if they've gotten away with it, the benzos are always tricky, and you never know if somebody's having a couple drinks on the side. And any sort of substance abuse, sleepiness, falling asleep in front of you, slurring their speech. I mean, you got to say to yourself, what am I doing here if they can't stay awake during their office visit and they're not working the 3rd shift. Any kind of, dropping 10 to 50% is probably reasonable. But any drop is a taper, you know? And so you don't have to be like, you know, it doesn't have to be in the 1 month time frame. You could think to yourself, this person's been on this for 10 or 15 years. I'm going to take this out over time and try to help them feel better. Clonidine, like I said, some people use this. I don't have a lot of experience. I don't use it at all. You can treat them symptomatically for all the other problems. Make a clear plan. That's all this means. Follow the urine drug screens and have them taper over time. None of this is anything that you have to really worry about. Tapering is very specific to you. It's specific to the person in front of you. Like I said, any drop is a taper. Sometimes you'll taper to a certain level, and then that's it. You know that's where they're going to stay. So I have some case scenarios, but it's 5 of 10, and in interest and respect out of your time, I'd really just like you to have the opportunity to ask questions if I've been unclear about anything, or if there's something that's on your mind that you would like to know about. The question is, yeah, some people come in with a 10 or 15-year history of being on polypharmacy, muscle relaxer, lorazepam, Ambien, so double benzos, opiates, and what would you taper first? So I will tell you, I would start with the muscle relaxer, because in general, people don't have muscle pain for 10 years. You have it in parts, you know, and I would start to take, especially if it's somebody that you're going to have long term and you don't know, I would take away things or not renew things that I really didn't want them on. You want them, when they have back spasms, to call you, and you give them a short period of time and confirm that it's really spasm, and that it's not something else going on. So, you know, you can have a herniated disc or facet arthropathy that can give you spasm, but that ends and other parts of the pain take over.
And you just stop that.
Yeah. I mean, you know, in general, if you look at people, they rarely take it consistently. Now, if they are, and there are people out there, then I don't think stopping anything fast on people who've taken it for a long time is that smart. I'd say cut back. I never cut back 2 things at once, because it's a setup to be tortured. So I would just start with the flexor, whatever muscle relaxer, cut it back, and then go to the opiate. While you're cutting back the muscle relaxant, you can look and see, why are they on this, right? If they're on an opiate for a reason that you don't understand, or is not really, you know, it gives you opportunity. Go to ortho, go to pain, go to neurosurgeon, whoever, you put them out there. And then if you're not getting responses back, that there's anything that requires the opiate, then you can start to kind of back up. It also gives you a chance to get to know the patient, because it'll take you more than one visit. I'm always hesitant about dumping benzos quickly. It's a dangerous sport. They really, really, really need like a rehab where they can protect these patients. It's very dangerous. So benzos seem to be like embedded in some people. So that to me is the hardest one, and I would probably, you know, employ my local psychiatrist to know whether the benzos are necessary, and then kind of go from there. The worst withdrawals I've ever seen were benzo withdrawals. But I would start, so start with simple, that you know you can back off on, and then learn. Take the opportunity to learn. You know, somebody comes on all those things for 5 or 10 years, tell them not to have a drink and stay out of a hot tub, and then give yourself a chance to like figure out the lay of the land. And that'll build a rapport with the patient for you, because you know they're coming from somewhere else and they don't know you, and then you're going to be like the hostile person who's going to stop. That never goes well. So if you can build some rapport, they'll believe in you, and then they'll maybe take your next suggestions better. Anybody else? Yeah.
Clonidine, you said you never hardly ever use it.
I don't. I mean, do people in the room use Clonidine? I did when I was at Jeff and we had inpatients, but in general, I haven't needed it. So, I mean, I know that it can work. I think you have to be cautious of who you're giving it to. You know, with our population on a lot of antihypertensive, you have to be cautious. But I'm not a Clonidine fan.
Because of the other antihypertensives that may be on board, or
yeah, and most people aren't on just a single anything anymore.
True.
Yeah. Yes.
Can you comment a little bit about the chronic renal pain syndrome? Because those patients have certain specialists that come to me with like multiple combinations of medication.
Yeah.
Totally sedated sometimes, not even being able to keep their eyes open.
Yeah.
And they keep increasing the dose.
Yeah. Okay, so complex regional pain syndrome, the question is, can you comment on complex regional pain syndrome, because they come back to their doctors on a lot of different medications, and her patients in particular are sedated and not themselves. I will argue, it doesn't matter what the syndrome is. If people can't keep their eyes open, the treatment's the wrong treatment, okay? So complex regional pain syndrome is a very tricky problem. It's a nerve. It's a neuropathic pain syndrome, and it's too complicated to get into here. There's lots of treatment early on, including lumbar sympathetic blocks, but you have a window of time with complex regional pain syndrome, and surgeons know this, particularly orthopedic surgeons and the hand specialists. They will send those patients very early on to pain doctors who do injections. So blocking the sympathetic chain in people under 2 years of pain, and if you can get them by 6 months, which is always tricky, because sometimes it's hard to figure out whether this is, say a fracture-related, natural response, or are they having these other symptoms. It's a very unusual diagnosis. They get odd swelling and hair and nail changes and things like that. Many people are misdiagnosed, but the truth is they're still neuropathic pain patients. So it's neuropathic pain, and then you have sympathetically mediated pain, and complex regional pain is part of it. So the reality of it is, in general, in the end, as people have it over time, the opiates aren't the way to treat those people. So they're treated with gabapentin, tricyclics, sometimes in combination. There are some doctors, and it's not all that well espoused, but they do IV ketamine and IV lidocaine, and all that never has actually been shown to have long-standing relief. Spinal cord stimulation actually has done a good job for those people if they qualify, but you have to have a lot. There's a lot to this. But I would tell you that opiates in general, in the end, in the long run, are not. They get them in the beginning because it's like brutal pain. But then over time, that should not be the way they're treated. Not for the long run. So, yeah.
What about with increasing patients' awareness about CBD oil and all the other alternative treatment? What do you generally recommend?
Yeah. So without getting into like a political nightmare, so this is the cannabis policy, and I think it's disastrous to get into a fight over whether cannabis is or isn't. Our policy is we will not write for opiates in the face of cannabis of any type, because we don't know the interaction, and we don't know how much they're getting, because the control on it is very different. You can buy CBD oil in the Amish market, or you can go to, it's like all these places that you can get it. It's not well regulated. So for us, and we're very, very non-judgmental about it. If a patient wants to try CBD oil or pot brownies or whatever they want to try, we're okay with that. We just take them off the opiates, and then they can try. It's interesting how that changes. By the way, it's very expensive. So I find it fascinating that people are drawn to this when they don't want to pay their copay. But it is what it is. They're going to get the card, right? They'll go to a physician, they'll get the card. That's a cash transaction, and then I think that you have to define who you are. For us, we won't write for that. It's the same thing for us with alcohol, though. If you come up with alcohol in your urine, like I said, maybe at Christmas and your birthday, we're not too worried. But if it's every single month, it's a problem for us. So in our practice, and many of you who have practiced like I have, for a longer period of time, cannabis was always a way to see where patients were headed. It was a gateway drug. In our community, it remains a gateway drug, and our psychiatry and addiction people still consider it a drug of addiction. Anybody else?
So how do you handle that when someone's developing tolerance, but your ultimate goal is to wean them off?
So the question is, the patient was post-op, had a colostomy, right? And had high requirements for pain medicine, requiring 4 milligrams of Dilaudid twice a day. And the goal was to wean the patient, but now there's tolerance in the patient. Is he or she getting continuous surgery?
Yes, she is. But it's a complex surgery, lots of complications. So she's had multiple surgeries, and so we're kind of always in these post-operative pain stages. This
is a difficult position for you to be in. So I think that the problem is when Dilaudid is about as good as it's going to get. Dilaudid, by the way, is excellent for bone pain. It's good for very bad pain. So I think you have to define what you're going to do. And I think you have to be very clear. And like I said to the girl with the foot, I'm not going to let you have a drug addiction issue on the other end. And so I think that's the conversation that you have to start with. Doesn't mean you're going to not give her the narcotic. She's going to not have pain control that's perfect. And then add in adjuvants. And I'm happy to talk to you privately, because I think there's other, there's other things that you can add in that may help her based on age and other things that she's taking that may help you reduce some of that edge. And you know what? She may have a lot of anxiety and depression and other things surrounding multiple surgeries. That's a terrible, it's a real hit when people get major surgery and they have a lag afterwards. They get depressed a little afterwards. So it may be that you need to treat a bunch of things at one time. If she's going through ongoing surgery, you're not going to get out of this yet. That's okay, but you're going to get out of it eventually, because the surgeries will hopefully stop or at least calm down. And then as soon as she's in between surgeries and the surgeons feel that she's appropriate, bring her down a little bit. You know, it doesn't have to be off. Bring her down so that when the next surgery hits, you have room to go. But and tell her, every time, if we keep you this high, when you go to the OR and when you come post-op, you're going to be in agony because we're not going to be able to give you enough to keep you because of the tolerance. So you're going to have to, you need a double appointment all by itself, you know, to have these discussions with this kind of a person.